Bismillah ar-Rahman ar-Rahim. Thank you, Professor Brackman, for acceptance of your attendance of our scientific day. Thank you, Professor محمد. Our lecture is about correlation between speckle tracking echocardiography and single photon emission computed tomography in post-myocardial infarction patients. Why speckle tracking and the topic of coronary artery disease? Speckle tracking is different from the other available diagnostic modalities for coronary artery disease in that it is of lower cost, non-invasive, high validity proved by many studies in the literature, and no special precautions are needed for speckle tracking studies in comparison to other modalities. Speckle tracking echocardiography in ischemic heart disease. Basic kinetics of speckle tracking depends on that each myocardial segment has a length in maximal systole, length in maximal diastole, and unlimited number of myocardial segments length between two lenses. Speckle tracking regional strain is the percentage of relative change in each myocardial segment from maximal systole to maximal diastole. So normally regional strain is a negative value. By 2D imaging of left ventricle, it is recorded in three views: apical 4-chamber, apical 3-chamber, and apical 2-chamber. Exported images are analyzed using EchoPag and external workstation. ECG monitoring is essential throughout the speckle tracking study. These are the views of that speckle tracking study is obtained. These are the views that we can obtain speckle tracking study. Apical 2-chamber, apical 4-chamber, and apical 3 chambers. Speckle tracking software allows manual pointing in the mentioned three views in 3 points: basal septum, basal lateral, and apex of the left ventricle. Left ventricle is plotted automatically in a 17 segmentation system with regional strain illustrated on each myocardial segment and the average global strain calculated automatically below the bullseye. Red segments mean that a regional strain is negative. More the red is dark means that the segment is more healthy, and the more red is light means that the segment is diseased or hypokinetic. Blue segments means that regional strain is positive value or dyskinetic. More the blue is dark means that the segment is more dyskinetic or more unhealthy. Why have we started speckle tracking in correlation with SPECT? In order to validate reference values in terms of regional strain by speckle tracking for both normal myocardial segment, ischemic segment, mixed scar and ischemic segments, and the total scar myocardial segment. The study was conducted on 60 adult individuals, 40 post-ST segment elevation myocardial infarction, and 20 healthy subjects serving as control group. Post-myocardial infarction patients were enrolled in our study 5 to 10 weeks after infarction to allow complete healing of myocardium by fibrous tissue and to arrange for maximal stress testing by SPECT. All patients with a history of acute ischemic ventilation infarction within the last 5 to 10 weeks documented by ECG, elevated cardiac enzymes, troponin, and regional wall motion abnormality at rest by conventional echocardiography study. Patients with myocardial infarction subjected to revascularization by PCI or CABG were excluded. Also, patients with poor acoustic window or morbid obesity, patients with arrhythmias either ventricular or supraventricular, patients with bundle branch block, and patients with contraindication to stress test. Resting speckle tracking echocardiography study was done for both post-myocardial infarction patients and control group in cardiovascular and ultrasonography research unit in Research Institute of Ophthalmology. Anti-ischemic drugs including beta blockers, calcium channel blockers, and nitrates stopped 48 hours before the procedure. Both groups were subjected to the following diagnostic workup: full medical history, complete clinical examination, 12 leads, resting ECG, conventional thoracic echocardiography, speckle tracking echocardiography, and only group 1 post-myocardial infarction group was subjected to SPECT. Regional strain value of each myocardial segment obtained by speckle tracking study in post-myocardial infarction patients with compared to the qualitative data of the corresponding segment obtained from SPECT. According to 17 segmentation system of left ventricle by speckle tracking, our study had analyzed 1,020 myocardial segments. Post-myocardial infarction group was 680 segments, and control group were 340. According to the results, respective myocardial segments in post-myocardial infarction patients were divided into the following types: ischemic segments, mixed ischemic and scar segment, scarred segments, and normal myocardial segment. Our results showed that ischemic segments in the SPECT were correlated to regional strain value more than -12, while mixed ischemic and scar segment were correlated to more than -11. The scar segments were divided into two groups: hypokinetic scar and dyskinetic scar. Hypokinetic scar was correlated to regional strain value more than -7%, while dyskinetic scar are more than 0. Normal myocardial segments in post-myocardial infarction group were less than -12% of regional strain. This is an example of our study showing that speckle tracking in the left side and systemic in the right side, showing large scar at the apex, septum, and anterior and infralateral segments, combined scar and ischemia at the anterolateral segment. Both results are typical in speckle tracking and SPECT study. This is another example: speckle tracking in the left and systemic in the right, showing large scar involving anteroseptal and inferior wall. This example shows large scar at the anterior wall, septum, and infraetical segments in both speckle tracking and SPECT study. This example shows the reversible anterior and lateral walls defect at the territory of the LED, and results are typical in both speckle tracking and SPECT. Also, our study has concluded normal values for global and regional strain in control sample of Egyptian populations, and it was around -21% for both regional and global strain in the healthy control group. Conclusion: speckle tracking echocardiography is a new, reliable, bedside, and a relatively inexpensive modality for detection of myocardial ischemia and scar tissues after acute myocardial infarction. Also, Also, our study is considered a provisional step for the clarification of normal reference range for regional and global strain values in a small sample of healthy Egyptian population. Myocardial and post-MI patients is considered eligible for revascularization if it ranges from predominantly ischemic myocardium over scarred myocardium to totally ischemic myocardium. The corresponding regional strain values for this range is less than -7% and to more than -12%. Regional strain values over -7% up to 0, which means more positive, are considered values of predominantly scarred non-viable myocardium over ischemic viable myocardium. Consequently, patients will not get a clinical benefit after revascularization. Regional strain values over 0, which mean positive strain, are considered values of total non-viable scarred dyskinetic myocardial segments that mean no indication for revascularization. Recommendation: stress speckle tracking echocardiography is considered is recommended in order to raise its specificity and sensitivity. Speckle tracking might be recommended as a preliminary test for primary and secondary care centers in patients suspected to have coronary artery disease in order to decrease load from the tertiary care hospitals. Pre- and post-coronary intervention speckle tracking studies are recommended for functional rather than anatomical assessment of cost-benefit value of those highly expensive procedures and for follow-up of those patients in post-intervention states in the short, intermediate, and long-term phases. Further studies are needed for evaluation of ischemic segment using speckle tracking in patients with no history of previous myocardial infarction. Finally, further studies are needed to investigate cause of discrepancy that was observed in our study between regional strain values in normal myocardial segments in post-myocardial infarction patients and in healthy individuals. Thank you.
Thank you, Mr. Heykel, for this interesting presentation. I have one question. Did your study take into account whether the patients had a successful revascularization at the time of myocardial infarction, whether the revascularization was not successful, or whether it was complete or incomplete?
Those patients enrolled in our study not subjected to revascularization. They only received fibrinolytic therapy and then arranged for SPECT and study group primary PCI strategy.
So, would the primary care for these patients in case of revascularization then be PCI or capital surgery to have a more complete revascularization? What is the strategy?
We only the patient subjects only to fibrinolytic therapy and then arranged for SPECT and the SPECT tracking study for assessment of fibrinolytic and ischemia, and then to the intervention state by either PCI or capital.
The decision is made, but then
yes,
on the SPECT tracking or on the result of the coronary angiogram?
By myocardium or myocardium, the upper to visualization.
So this use in practical would be so would be good, interesting to compare those values with those we have determined in German populations responding the same way. Yes, very interesting.
Not a very high rate of success with the streptococcus values, and they claim this for the resistance we drew from the throat infection streptococci. They said that the Egyptian population has a higher incidence of resistance to streptococcus therapy.
Maybe either it could be a change to another lytic agent, or maybe also maybe availability of more acute intervention in the future, maybe also cost depending on the resources. We are current time, I would say, almost every patient goes to primary. So I think we have almost complete lost. Yes. Then we still have urokinase, which may be less expensive for telectase. It's also being used, yes. But again, it's really when it's not availability of the BCI. I think just over the years, I think this has been developed over the last 10 years. Also not kind of old, but we have now more. Besides, as you said, the availability of technology needs to move from tertiary to secondary care centers. So also, when we started, we were the only BCI center, let's say, for more than 1.5 billion population. Now it's 1/2 more BCI centers established.
Lecture of cardiology at Kasmani Hospital at University to talk about MRI, clinical situation, cardiac MRI,